95 to 98% of men that walk in my office, the cause for their hair loss is androgenetic alopecia. The cause for this is three factors. The first one is genetics, the second one is a specific hormone called DHT, and the third one is simply aging. So what happens is you get the gene for hair loss from either side of your family, and make note that it can actually skip generations. So once you go through puberty, you start to make DHT from testosterone, and that activates the gene for hair loss. So you may get some patients in your office as young as 16, 17 with early stage hair loss. So as we get older, you have an increased risk by 10% each decade of more thinning or more loss. So at 50 years old, you have a 50% chance of thinning or loss, 60, 60%, et cetera, et cetera. So you make the diagnosis for androgenic alopecia by looking at the miniaturization of hair follicles. So with each patient, I use a dermatoscope, and I will place that on the patient's back of their head, the occipital region, and that is their baseline. We generally do not lose our hair in this horseshoe zone because the DHT that attacks the hair on top does not affect the back and sides of the hair. So we use this as a baseline to measure the count or the follicular density of the hair as well as the thickness. And then we will compare it to different zones on top. So what happens is with DHT, it will attack your nice hair and over time essentially strangulate it. You'll have less proteins and nutrients and oxygen and blood supply. So over time that hair will thin out until it goes completely bald. So the goal of non-surgical treatments is to work on the hair that you see, the fuzzy, thin, weakened hairs, and either prevent them from getting worse and going completely bald, or actually reverse them and re-thicken them. Hair transplant surgery will actually put back hair where it used to be. Every consultation should begin with a physical exam after you've discussed their history. You should always look at the skin architecture and make sure that there's no underlying scalp disease. If they have had a history of eczema, psoriasis, dandruff, find out if they've ever been to a dermatologist or have done any treatments. If I see a scalp that is very inflamed, reddened, or does have some sort of flare-up with psoriasis, eczema, etc., the goal is to really treat that before you perform a hair transplant surgery, because if you can think about the scalp as the soil, you don't want to implant brand new hairs in poor soil because they just won't grow as efficiently. So you really want to make sure that they are clear of any sort of skin disease. So when you are doing your physical examination, if you do notice that a patient has some sort of disease or inflammation of the scalp skin, if you do not treat that in your own practice, I always recommend sending them to a dermatologist and having them treat that. So once the patient has seen the dermatologist for whatever skin disease that they have, I do like to wait at least 6 weeks to make sure that the skin is nice and healthy before implantation. The Norwood scale defines male pattern hair loss, 1 being normal and 7 being the most advanced. Level 2 is just a little bit of frontotemporal recession. It's more of a mature hairline. And when you get into level 3, that's where you have more frontal loss with a little bit of thinning in the crown. As you move more into level 4, 5, and 6, and 7, you have more loss moving backward. So when you perform your physical examination with the patient, it is very important to look at the donor area very carefully. I happen to use a dermatoscope that plugs into my computer, and this gives us a magnified view of the patient's hair follicles. We're able to calculate the follicular density, which is the number of hair grafts in a given centimeter, but also look at the skin architecture and the characteristic of the hair follicles. This is very important for when you're planning your surgical treatment with the patient. So what you'll do is you'll use the dermatoscope. You'll start at the back of the head, which is the area we generally don't lose. This is what we call the permanent zone. And we use this as a baseline to compare to other areas of the scalp so that the patient can see how their hair has changed over time. Patients want quantitative and qualitative evidence that what they're doing is working. Designing of the hairline is extremely important. Of course, the hairline defines a person's face and can restore their youth, so you really want to take a lot of time when you plan and design your hairline. The first thing that you have to do is make sure that the patient has realistic expectations. Our goal is not to draw very low hairlines. We want this to be naturally unnatural and to progress with the person as they become older. The first thing that I do is I will examine the facial features, if it's long, if it's wide, determine based on their race and gender as well. Then I usually use the rule of thirds, so I will do 1/3, 1/3, and 1/3 and make sure that those are the appropriate dimensions. I will make that point right in the center. Then I use the mid-pupillary lines to define the part where the hairline starts to go backwards. Then another important part is to find the apex of the frontal temporal points. So I do two things. I use the lateral canthus to be my outside border, and I'll draw a point on each side, and then I stand to the side of the patient, and I will use their sideburns as to know how far back to make that point. So if I use my sideburn here, the front of this sideburn is considered an aggressive hairline. The midpoint of the sideburn is considered more conservative, if you will, and then the back of the hairline is way more conservative. So I will determine that based on the person's age as well as how much loss they have. For example, if someone is already thinning out on their temples and they're already here, I'm not going to give them an aggressive hairline because that will not match. So you have to assume that if patients are more advanced, they may over time lose this temporal hair, and you don't want to give them a very unnatural look. Now, in regards to the angle of sight making, it is very important that you alter the angles as you move from front to back. Too many patients will come in with their hair spiked straight up, and that's because, unfortunately, where they had gone, the surgeon made the sights straight up. You want to keep the angles at 10 to 15 degrees from the hairline, and as you move back, they slowly fan up to about 35 to 45 degrees, depending on what part of the scalp you're at. So when you first start out, your natural tendency will be to go more higher up. You really want to make sure that you are angling your sights forward, because hair cascades forward on the hairline and slowly will fan backward as you move back. Okay. Now, in regards to direction of sight making, every patient has different direction of hair. If a patient is completely bald, clearly you have a clean palette and you can make whatever direction you want. But you need to use your loupes and first get a lay of the land and see the direction that the hair is flowing. Sometimes patients' hair will fan outward, sometimes they'll fan inward, and you'll even have patients that have cowlicks on their hairline. So you need to notice how the hair is changing. You can use a marker so that when you're in there, you can follow the lines that you've created, but you're doing your patients a disservice if you're going against what the direction of the hair naturally is. In a situation when a patient has advanced levels of hair loss and there is no hair, you essentially have a clean palette and you can choose the direction that you want. Every surgeon will have their own style. For myself, I do like to converge the hairs somewhat inward because hair will fall to the side. And if you go more straight and the hair falls, you might see a little bit of gaps or thinning when the hair falls downward. So I do like to converge ever so slightly inward. So this is what I explain to all my patients. I go through about a 10-15 minute discussion of what to expect on the day of surgery and how the procedure works. So essentially, we require that the patient shave the back and sides of their head with a zero guard. That is in order for me to be able to see the hair exiting the scalp so that we can get the vacuum-assisted punch around the hair follicle and safely extract it without creating any transections. He may keep his hair as long as he wants on top because we will spray water and go through his hair to create the sites should he have some hair left. In addition, we also give them a Valium 30 minutes before in order to make their stay more pleasurable. And I offer laughing gas when we inject the local anesthesia both to the donor area and to the recipient site. Throughout their day, they will have access to cable and Netflix, and we provide them with food and snacks, and of course they can get up and stretch whenever they want, but they will not feel the procedure once they are numb. So the initial part, we will have the patient lie face down, and we will begin the extraction process. For a 2,000 graft case, it should take anywhere from 2 to 2.5 hours to extract the hair follicles. Then we will sit the patient up, I will inject them with PRP, and then I will go ahead and make my sites. That should take anywhere between 1 to 2 hours as well. We will then provide them with lunch, a quick 30-minute break for him to stretch and eat, and then we begin the implantation process where we will implant the hair follicles one by one. That process should take about 2 to 3 hours as well. And on any given day, if the patient arrives around 7:45 for a 2,000 graft case, he should be gone by about 4:30, 5 o'clock. So every physician will have their own post-operative information. For me personally, I do not want the patient to wash their hair for 48 hours. Then for the next 7 days, the patient will be provided with a soft sponge and he can go into the shower, fill up a pitcher with warm water, pour it over his scalp to soil it, and then he will dab with shampoo for 7 days. After that 7 days, he can go back to normal hair washing and he will softly massage his scalp to try to remove those scabs using the fat pads of his fingers. And we always reiterate, never use fingernails because that may carry bacteria onto the scalp. In regards to the recovery process, the patient likely will have scabs and redness for about 7 to 10 days, depending on how well he washes his scalp after. He may get a little bit of dullness or numbness to both the donor area and or the recipient side area. The reason being, of course, is that we all have superficial nerves that run throughout our skin. So when we're breaking through the skin, we may be damaging those nerves. They will, of course, regenerate for the most part. And within a few weeks, the patient should have full recovery of that feeling in the back of his scalp as well as on top. Patient expectations is something that is extremely important. This may rule out a person to be a candidate for hair transplant surgery. If you have someone who is very, very advanced level of hair loss and expects to look like Elvis Presley in 1 year, you have to really be cognizant of those patients' thoughts and feelings and make sure you talk through it with the patient so that they do leave your office with realistic expectations. I like to design hairlines if a hairline is required, and I take a photo of that hairline so that when we arrive on the day of surgery, we are both on the same page. Every race has a different hairline, so you do not want a person to come in wanting a very low hairline or a hairline that does not match its facial features.